Good afternoon and welcome to today's SAMHSA-sponsored webinar titled Crisis Intervention Teams, Partnering with Families of Loved Ones with Serious Mental Illness and Serious Emotional Disturbance, presented on behalf of the National Federation of Families. Today's presentation will be recorded, and the recording link, slides, and a certificate of attendance will be sent via email to everyone who attended today. Closed captioning is available and can be viewed by clicking the CC icon at the bottom of your screen or clicking the link in the chat pod to view in a separate window. We also have ASL interpreters who should be seen spotlit on your screen. During the presentation, please add your questions and comments in the chat box, and questions will be asked out loud for the presenters to answer at the end of the presentation. When the presentation ends, please take a few moments to complete a brief survey that will show in your browser as you exit the platform. Thank you again for joining us, and we will now begin today's presentation.
Hello, thank you all so much for being with us here today. My name is Dana LeBranch. I'm the National Certification Manager for the National Federation of Families. We are a family-run national advocacy organization that supports families of loved ones with behavioral health challenges, as well as the family peer support workforce that supports those families. We're really excited for you to be here today to learn from our three great presenters about crisis intervention teams. We hope by the end of our time together that you'll be able to better support families of loved ones with SMI and SCD to connect with community support so that they can avoid justice system involvement. That is really the goal of CIT. We also hope that the presentation today will help you be able to connect police departments with CIT training to support those individuals, and so that police officers can better understand the best practice of co-response between police and community stakeholders. And 988 and the sequential intercept model of CIT is a really great support to those police officers and community stakeholders. We also hope that today's presentation will explain how some of the key concepts of CIT training prepares officers to best support individuals with SMI or SED. Like Bailey mentioned, throughout the presentation today, you can add questions to the chat, and we will be collecting those to answer at the end of our time together. If you would like to learn more about NFF, I'm going to put our website in the chat as well, and we can go to the next slide to introduce our lovely presenters. We're really excited about the presenters that we have for you today. First up is Muriel Jones Banks. She is the founder of Courage to Be LLC, and she's also one of NFF's past affiliate executive directors. She is a true family champion, and her story today is going to really highlight that. Next, we have Lieutenant Stephen Thompson from the Anne Arundel County Police. He is one of the most award-winning CIT officers you have out there. He is a really great person to be explaining how CIT works because he has been through it. Finally, we have Madonna Campbell-Greer, who is the CIT coordinator and train the trainer for the CIT International, and she has been instrumental in developing and training CIT throughout the country, so we're really excited to have her with us as well to help us better understand how we can spread this wonderful program to more communities. I'm not going to take up any more of your time. I'm going to pass it right over to Muriel, and we'll see you in about an hour.
Great. Thank you, Dana. It's great seeing you. Hello, everyone, and thank you for being part of this fabulous webinar. Thank you, SAMHSA. Thank you, National Federation of Families, for allowing me to participate in this webinar. My name is Muriel Jones Banks, and I am the mother of a 41-year-old daughter and 34-year-old son. I retired in October, serving as the executive director of Federation of Families of Central Florida. I founded Courage to Be LLC, which helps me to continue my purpose and my calling to translate lived and professional experience with practical guidance, providing speaking content, strategic speaking content, consulting and resources that drive tangible improvement. And for some of you who do not know me or not familiar with my story, My 34-year-old son has a co-occurring mental health diagnosis. I describe our journey as the same book, different chapter. Each year represents a chapter. So next month, he will be 35 years old. Therefore, we will be turning the page to chapter 35. Our journey has not been easy, as most of you know, and I know I'm preaching to the choir because I'm pretty sure we have families and caregivers supporting a loved one, whether it be a child or adult child. Our journey consisted of isolation, frustration, being judged for making very difficult decisions, setbacks, growth, successes, and actually hope. I felt lost and afraid navigating systems. And when I say systems of care, that could be mental, behavioral, judicial, educational system. Those systems sometimes did not always know or how to respond to my son's needs. I knew it was up to me. It was up to me to learn, to take all my love and emotions and make them actionable steps to understand how to effectively navigate and advocate and bridge gaps for my son. I had to step out of my comfort zone. I had to step out that box. I had to make myself feel uncomfortable in order to make this happen. And that meant playing nice in the sandbox. You have to play nice in the sandbox with systems of care and doing what needed to be done, not because of what I was feeling or what I wanted, but what was in the best interest of my son. So while I'm bringing to the table both lived and professional experience to this work, I can honestly say 90% is lived experience and 10% professional. Because before I stepped into a boardroom, before I stepped into a meeting, before I stepped in as a commissioner sitting on a commission, I was a mom just trying to keep my son safe and that he's seen and that he's supported. While I'm here today is to share how CIT and families can create a partnership of hope. You can go to the next slide. Well, first of all, you have to partner for safety and understanding. And I had a parent ask me, well, why would you do that? My question, it really was an answer, was why wouldn't I do that? I had to do that. I didn't have a choice. So if your city, your town, your local law enforcement agency does not have CIT officers, then you need to connect them with CIT International or National Alliance on Mental Illness, NAMI. They offer CIT training and resources to build understanding and promote safe response practices. It is an awesome program and it works. It gives the law enforcement officers the tools that they need to interact with an individual with a mental health diagnosis, in a crisis. It is a great program and it's definitely needed. And it's a resource and a support out there for families who may not know it even exists. Before CIT was actually implemented in New Jersey, I'm from New Jersey, I live in Florida now. Before it was implemented in New Jersey, I had to figure out how to engage with law enforcement because I had to make that 911 call. I had to. My son has violent tendencies. He would fight me, attack me. I could be asleep, anything. So I had to be intentional on, I need that type of support because I was not good at de-escalating. I'll be perfectly honest with you. I'm a mom. If my son is confronting me and he's confrontational and aggressive, I'm going to be that mom. I'm not going to be try to de-escalate. I'm a mother. You're not going to do that. So I was not doing the right thing. I actually wasn't. I wasn't doing the right thing. My emotions were involved. So I made it a practice. I was intentional. Wherever I lived in New Jersey, whether it was central New Jersey or South Jersey or North Jersey, I made sure the police department knew who my son was and who I was. And this was, like I said, well before it was even a thought in New Jersey about CIT. I would take him to the police station with me. This is who I am. This is my son. This is what we're dealing with. These are his diagnoses. You are going to get a phone call from me for help. And I need you to come and help. Maintain the peace. But please help me with my son. And it worked. I started establishing relationships with the police department. Definitely out of my comfort zone, but I did it because you're sharing what's going on in your home. You're sharing what's going on in your home. Remember, I was feeling isolated. I like being in my little silo. What's going on in my home stays in my home. But it was getting to the point I needed help in a very bad way. So going to the next step, you're building this trust, this relationship before a crisis hit. Families can advocate for the child by providing valuable information to local law enforcement and requesting that a CIT-trained officer respond when possible. Now, will there be a time you call and they say, we don't have a CIT officer available? Now they have them, but guess what? They're out doing their job. They're doing police work. They're not sitting around waiting for that 911 call. So what do you do then? You provide all the information to that dispatcher to relay that information to that unit, to those law enforcement officers who's going to come out to the home. Well, this is it. My child or my loved one is suffering from this. They are pacing. There's property damage. Don't sugarcoat anything. Don't say, well, they're having a bad day. Be clear on what's going on in the home. If you're afraid, say, I'm afraid right now. I used to stay on the phone. I wouldn't hang up on the phone. I would say, keep me on the line until someone gets here. This trust, this relationship you're building is crucial in moving forward because the ultimate goal is to have hopeful outcomes. So we get to creating hopeful outcomes together. Now, through your advocacy, when I say you, I mean me and you, we are going through this journey. Whether you're a parent, a caregiver, I don't care who you are, you're caring for a loved one with a mental health diagnosis. It's up to us to bridge that because we're coming to the table now with lived experience and we're advocating effectively for our loved one. I keep saying effectively because you can advocate, but you can be oppositional. You don't want that. You want to be an effective advocate so that you nurture these relationships and you build these partnerships, not for you, but because what's in the best interest of your loved one. So through your advocacy, preparation, and partnership, families and officers can turn crisis moments into opportunities for healing, trust, and lasting support. And that's what we need. And before I go to the next slide, I will share that in a prior presentation, this slide I presented on. So I'm just going to set up the scenario, what happened. My son at that time, this was in 2015, 25 years old. 25 years old. He could no longer live at home with me. So I had him in a group home in New Jersey. I was at that time living in Florida, but still his guardian. The mentality of a teenager, maybe 13, 14 years old, but he's 25 years old. He decides that he's going to elope. He's just going to leave 1 o'clock in the morning out of a window, out of his bedroom, just because he wanted to go to a 24-hour convenience store. I didn't get a phone call from the group home. They, of course, called the police. But it was the dispatcher then that said, I need to speak to the guardian. I need to speak to the mom. What's her number again? Give a number, gives me a call and says, hey, the group home tells me your son eloped and they don't know what he's wearing. Is there any way you can get in touch with him? Because apparently he's not answering their phone call because he has a cell phone. And I said, sure, I'll make that phone call. He'll pick up the call if it's me. I said, but have you been informed about his condition? He said, no, they didn't give me any detail really, except for he was gone and to pick him up. So I explained and shared everything, my son's condition. He gets very nervous. He's a runner. I didn't know his frame of mind that he was in when he eloped. So the officer said, call him, find out what he's wearing. I'll send a unit to pick him up. I did that. My son picked up the phone as if nothing. I said, how's it going? What are you doing? Where are you? Oh, I'm home, sleep. What did I say, mothers? No, you're not. No, you're not. But then I remembered, oh my goodness, let me control my temper right now, because now I'm upset. I don't want to trigger him, and then he runs off. So I had to take a step back, and I said, I'm worried about you. I don't think you're home. I don't think you're in the bed. I needed you to be honest with me. He finally said, well, I left because I wanted to go get some cigarettes. I said, well, you know what? It's dangerous out there. It's nighttime. I need you to be safe. I did not want to say I was having a police officer to pick him up. What I said was, first, what are you wearing? And he told me what he was wearing. And it was then I said, well, guess what? I'm going to have someone pick you up. It'll be a police officer. And I'm trying to make it casual. And he's like, no. I'll walk home. I'll walk home. I said, no. And I had to think quick. My son, believe it or not, is afraid of certain animals. And deer, he's afraid of, because where we used to live, there was always deer in the backyard. He don't like any type. Dogs and cats he could put up with. Any other animals, he has zero tolerance. So I had to go there. What did I say? Oh, well, it's really dark and there's a lot of deer out there. And he was like, oh, I forgot. I said, yeah. I said, deer, possums, raccoons. I threw every animal in except for lion and tigers. And he finally said, okay, Mom, I need the help. I need the help. So I hung up with him. I said, I'll call you back. Let me call the police station. I spoke to the dispatcher and he said, okay, we got it. All right. He said, what does he like to be called? Does he have a nickname? I gave him his nickname. He said, okay. Call my son back. So answers the phone. And I told him that officers are coming and you're good. As the officers apparently approached in their vehicle, my son got nervous. Oh, they're here, Mom. I don't think I should be here. He's getting real nervous. So I just said, I am so proud of you that you're standing here waiting for law enforcement, for the police. I said, because Mommy is really worried about, I had to go there. I had to go there with him. When I heard, now the officers didn't know I was on the phone because apparently my son didn't have the phone up to his ear. He had some kind of earpiece in his ear or whatever. I heard the first officer call him by his nickname, as if he knew him. And he said, called him by his nickname and said, what are you doing out here? Oh my goodness. Buddy, what's up? And then the other officer says, because I described everything he had on, he said, so you're a Philly 76ers fan and you're living in New Jersey? Come on. New Jersey Nets. And he engaged in a conversation with him. And my son is kind of giggling a little bit. And then finally the officer says, there are so many people worried about you. And we want you to be safe. You're out here on this dark road. It's not well lit. He said, come on, jump in the car. We're going to give you a ride. We're going to take you back home. My son whispers to me, should I get in the car? I'm thinking, you know what I said, get in the car. I'm like, get in the car. So he gets in the car and finally disconnect. And when I finally spoke to the group home, they let me know that Michael was safe, he was safe, and that also the police stayed there for about 30 minutes and just had a conversation with him. Just had a conversation with him. Next slide. So what did I do the next day? I had to acknowledge that because I actually heard how they engaged. I know this is a tiny print, and I'm going to read it from my big print on my slide here. But I sent it to the chief of police. And I said, this letter is to commend the police department concerning my son. And I put, of course, 25 years old, suffers with a mental health challenge, and is on the autism spectrum. I received a phone call at approximately 12:53 a.m. on Saturday, August 8th, from an officer advising that a call was received from the group home residents, reporting that my son ran away. The officer identified himself, and unfortunately, I do not recall his name. It is my hope that your call log will reflect the officers involved, including dispatch. I was able to track down my son via his cell phone and advise dispatch. I was on the phone with my son when the unit arrived at the BP station. And then, of course, I'm in the street. The approach by the officers was absolutely amazing and brought me to tears. I am not sure if they were CIT trained, but their approach was sensitive and professional. I truly appreciate the professionalism of dispatch and the officers who encountered my son. I thank them from the bottom of my heart. Why this is important? They need to know that they're doing a good job. It validates what they're doing. It also says that this program, the escalation program, the IT program, is working. Next slide. Next thing. Next day, I received, as you can see, 6:33 in the morning from the chief of police, who was on vacation. Thank you for recognizing my officers. We do have specialized training to deal with people that have autism and special needs. It is something I identified as a need upon being chief of police. It is imperative that we meet the needs of all of our residents to provide the best possible quality of life. I'm away this week on vacation, but I am having the reports pulled so I can forward your letter to all the officers and communication staffs involved. I will place this letter in their personal file. Complimentary letters are considered for performance evaluations, special assignments, and promotions. On a personal note, I want to tell you I sincerely appreciate the compliment. I am sure you're aware that law enforcement has been under a great deal of scrutiny and criticism lately. It is quite refreshing when my officers are recognized for their hard work and dedication. Feel free to contact me if I can ever be of assistance. Have a great week. Wow. That's what they needed to hear. And yes, I ended up contacting them because they ended up going back to the group home a few times more. And they were just absolutely wonderful with my son. The next incident that happened actually just happened recently this year, a few months ago. And I will say that it was scary. It could have gone to the left. My son was hearing voices. And this is a different group home. This is a newer group home. I put him in a very nice group home too in Jersey. He was hearing voices. He was out in the street, the neighborhood he lives in. And staff was not able to de-escalate nor to control some of his behaviors and some of the things he was saying, of course. It could have been a tragedy. But for the sake of, again, partnering with law enforcement makes such a difference. Now, the one particular officer that showed up was familiar with my son. The other one wasn't, apparently. But everything worked out for the good. And what they decided to do, which I thought, instead of taking him to the hospital that he normally takes him to. This particular officer, because of how many times he had to interact with my son, said, you know what? We're going to take him to a different hospital for an assessment. Because right now, that hospital is keeping him maybe 24, maybe 72 hours and not doing anything. We're going to take him to this other hospital. And they gave me a call and let me know. And I said, thank you so much. And then I let them know that I was in the process of having him move, working with the state of New Jersey, because I knew, as much as I loved that group home, the staff was not able to meet his needs, nor was he getting the appropriate supports to be successful. That hospital kept my son for about 6 weeks until the state and I were able to get him into a facility that was better suited for him, but that also my son agreed to. Next slide. So thank you. After, I guess, once we had everything settled, I sent a follow-up email to them. So this is the most recent email. And I sent it to the captain of this particular township. I want to commend your officers for their interactions with my son, doing multiple calls to and of course I named the group home. While I am unsure whether the officers who responded while my son was a resident at this particular group home were CIT trained, I wanted to acknowledge that each encounter was handled with safety and care. My son lives with a serious co-occurring disorder, and the compassion and patience your officers consistently demonstrated during his stay at the group home should be recognized and commended. My son is now in a facility better equipped to meet his needs. Sincere appreciation to the name of the Township Police Department for their professionalism and keeping my son, and Lord knows, the community safe. Next slide. Next day, I received a response. On behalf of the name of the Township Police Department, I would like to thank you for extending your appreciation for our interactions with your son. As I'm sure you're aware, mental health calls can be some of the most difficult for officers to navigate. Lord knows, I get it. I get it because I live with it. Our officers regularly train to deal with a multitude of issues that we may encounter during our shifts to help achieve the best possible outcome given the circumstances. One of the areas we have focused on over the last several years has been de-escalation techniques. These techniques are aimed at giving officers additional tools when faced with difficult situations. I am glad that we were able to help your son during some difficult times. This is the part that I really appreciated. I will pass your message on to our patrol division. We hope, and look what I put at the top, a partnership of hope. We hope, that meant they cared enough, that he has great success in his new facility and will not need further office interactions. That's what I would like to see happen. No longer would he have to interact with officers, that he would be stabilized one day. Again, if there's anything else we can help you with, please let us know. They provided enough information that the state and I were able to get him into a facility that is better to meet his needs, to justify why he needed to be there. Next slide. That's why, and I'm ending on this slide. It is so important, and I know I'm speaking to families on this. Hear me and hear me and receive this. You have the power, you have the influence, and you have the experience to bridge this, to connect with these systems of care, and to lead the way. We're driving the bus, I'm telling you. We're driving the bus and helping build these robust programs to support our loved one. So I end with strong community collaboration, support from national programs, and commitment from police leadership. CIT training can be obtained and a robust CIT program built, leading to safer encounters and improved outcomes for all involved. Remember, it's about the community. You need to be the bridge, help build a community ready to respond with compassion. Dana, I will also ask if you could, put in the chat my email address if anyone needs to connect to get a little motivated, to get a little guidance, because this is a difficult journey and it's forever. It's across a lifespan. It really is. And it would be, if you could give them Muriel, Muriel, at Courage to Be LLC, all one word, .com. They can reach me. And that one too, mjb.couragetobellc@gmail.com as well. I thank you for your time, and I hope this has resonated and will help someone that's out there. You are not alone, and there is help out there. Thank you so much.
So, good afternoon, everyone. My name is Steve Thomas, and my title is I'm a lieutenant with the Anne Arundel County Police in Maryland. However, what I truly am is a peace officer. I don't look upon it as I'm a law enforcement officer. And we just heard the goal of what we do is to keep the community safe, and that includes all members of the community. One unique thing about me is I live in the community where I work. I live in the same neighborhood I grew up in. When I was a patrolman, I patrolled my neighborhood, and it gives me a little bit different perspective, I believe, in what my role is in the community. Next, please. So I don't want to dwell, because we all know the statistics, but when you look at this chart and you look at the prison population, starting in 1972, and it really, I hate to say it, we started to criminalize mental health challenges, substance use challenges. Next. And again, I don't want to look in the rearview mirror, because I always say that we have to look forward where we're going. But some of the reasons, people weren't treated as patients. They were called patients, but were they truly treated as patients? Also, we're always looking in everything we do for a simple fix, and nothing is simple. It is complex. We have complex challenges, and we need to have complex solutions for them. Excuse me, next slide. So again, this is just some studies that show that we started to criminalize behavioral health challenges, and we weren't being helpful to people and helpful to families in their time of need. We actually were being extremely hurtful in those times. Next. So with that, we need to have progressive policies. When you look at it, that the three largest inpatient mental health institutions are our three largest jails: Cook County, LA County Jail, and Rikers Island. Where is that where people should be receiving mental health treatment? The problem is, we as a society look at it that when they were patients and they weren't treated appropriately, that was horrendous. But now they're prisoners. So as a prisoner, if we don't treat them properly, is that okay? They don't get the right service? And I say it's not. And that's where, next slide, we're looking at what can we do to move forward to help people. And I think it's really important to look at the sequential intercept model. Where can we provide assistance to people? Perfect world is intercept zero, where there's not any criminal justice involvement whatsoever, and everything is based in the community. Next. So how do we do that? Well, we've had a lot of success. And I should have said this earlier, my CIT unit is pretty unique. In our county, we have approximately about 28% of our officers are voluntarily trained in CIT. With that, we have our CIT unit, where it's myself, a sergeant, and I have 8 officers, where we are fully integrated into our crisis system. which is really unique. A lot of it's the way we make it work for us, and that's the uniqueness of CIT. CIT, it's more than training. It is that we're all working together for a common good to keep everyone in the community safe. So with that, we use psychological first aid as a basis for what we do. And this is the Safe for R model developed by Dr. Everly and Dr. Mitchell. Next slide. So as that, we stabilize, we talk to people, introduce ourselves, let them know that we're there to help. We're going to try to do whatever we can to make sure they're safe. We're going to take care of their Maslowian needs. We're going to stabilize the situation, keep positive influencers there, do things that are helpful, and build a relationship with that person based on their individual needs and who they are, and what they need and their family need. Next slide. We're going to acknowledge that there is a challenge. We're going to let them tell their story to us. So you think of it two different ways. Behavior is a criminal behavior, or is it the symptom of a mental illness or a mental health challenge? And it may be both. So we're always going to look at it as a symptom of a mental health challenge, but listening to their story, listening to what they've experienced in the past, acknowledging the trauma that they've experienced in their life. With it, I mean, think of some of the stories that we hear all the time of people with a mental health, emotional challenge, the way that they've treated by law enforcement, but not just law enforcement, other community members, and even at times those that are supposed to be helpful within the mental health services. Are they getting the help that they need? So listening to what they have to say and acknowledging what they've been through, but also letting them know where they're going to be going. And I say that it's giving them hope. Next slide. So facilitating the understanding, letting them know that they're not alone. They're not the first person, and other people have their stories. And we always say that our stories they're unique to us as an individual for our personal stories. However, with that, we all have similar stories. As I've been told by a friend of mine once said, we've never walked in someone else's shoes, but we've been in the same shoe store, the same aisle, same style, maybe even the same size, just not the same exact shoe. So letting them know that they can be successful for what's best for them. Letting them talk about what they've experienced in what they've gone through. Next slide. And now really important is helping them with positive coping strategies for them, what helps them as a person. We always, again, looking for quick fixes. We always want that one thing, and it's not that simple. It's, are we linking someone to additional services? What is best for them? How do we teach them that not just we as a peace officer should be de-escalating people, but can't we also teach people how to de-escalate themselves and how important that is? Next slide, please. And I apologize, I'm going through this really fast, but we're given the 20,000 because I really want you to hear people's individual stories. So we're going to be linking people to appropriate mental health, behavioral health services, job training, social programs, linking them to services that they need. And whatever it is, again, we're treating them as a person. It's based on what they individually need that's best for them. Next slide. So how do we do, I just went through psychological first aid. It's actually a 2-day class through the International Critical and Stress Foundation that I just gave you a 5-minute blurb on. But how do we use those skills in Intercept Zero? Next slide. So Intercept Zero, Intercept One, community services, and law enforcement. And I look at it, law enforcement again. I am a police officer by title, but what I do is I'm a peace officer. Next slide. So working in crisis response, what do we do and how can we help people? So we have a program called hospital diversion. It's following up on the help that person and their family when they've been taken to the hospital. In Maryland, it's called the emergency petition. In Florida, I know it's called a Baker Act. But what can we do to help that person? Think of the revolving door when you normally go to the hospital. You go in, you're seen, you're stabilized, and you're sent home with a packet of papers, and this is what you need to do for follow-up. It's confusing in any circumstance. But when you throw in there the person that their history and their experience and how they may not have been treated well by the system, it can be very frustrating. So we're going to help them navigate that behavioral health system, help them get follow-up. And it may be that that we as police, as peace officers, as CIT officers, are taking people to appointments. Our clinicians work to make sure that they get appropriate follow-up, but then we get to be that part of the solution. Some people may look at it and we're an Uber driver, but guess what? That's where we build the relationship. And we're talking to people and letting them know we're there to help. And what better community policing is it to do that? Next slide. So this is Melissa's story, and Melissa shares her story. Melissa was the 2023 CIT International Person with Lived Experience of the Year. She is a public school teacher, and she was taken to the hospital on an emergency petition for behavior which she could have been charged. We in CIT followed up with her while she was inpatient. We developed a relationship with her while she was inpatient and worked on her treatment plan. By being another social support, her family was sensational. And we've heard earlier about the role of families, but we're also there to help. She had PTSD from some of the experiences when she was having psychosis while she was in a manic episode. And I wish I could I had the time to really get in depth in the Melissa story. So please, it's her presentation as Patient Not Prisoner, How CIT Saved My Life. And please look at it because it's imperative that long-term follow-up that we did. And she is the biggest advocate for us in CIT because of that she was treated as a patient, not as a criminal, not as a prisoner. And she talks about that the same behavior she could have been arrested for. If she would have been arrested, she most likely would have lost her job. She loses her job. She loses her health insurance. She would have lost her house, and she'd probably be unhoused now walking the streets. Instead, because she was treated as a patient, she is a thriving public school teacher helping a lot of our young people, and she's actually the head of a psychology club at her high school. So next slide. So pre-arrest diversion, emergency petition, and charging. These are situations in which the person is going to the hospital on the emergency petition. However, they're still charged for their behavior. There was criminal repercussions to the behavior. But we want to get them stabilized first. It does absolutely no good to take someone to jail or take them to court if they're in a mental health crisis, or if it's substance use, if they're in active withdrawal or actively using. So we take them, we get them healthy so that when they do go to court, they understand what has happened. They understand the repercussions of their behavior while they were in crisis. Next slide, please. So John's story. John goes to the hospital on emergency petition. He's also charged on application. With that, upon being discharged from inpatient use, inpatient from the hospital. We as a CIT team pick him up, take him to central booking. We make sure he's represented. If he's released at central booking, we will be there so that he's not walking out unhoused or without any services. We go back, we pick him up and make sure that he's receiving the appropriate mental health treatment. If he's held at that initial hearing and goes to bail review, we do the same exact thing. We go at bail review and we will advocate for his recovery. Now, I say this as John's story, but we do this at least once a week, if not more, with numerous people. And where this came from was actually at the Maryland NAMI conference. I was at a presentation from the ACT team from another jurisdiction and heard them in their presentation. They talked about that they had someone they were working with. The person was inpatient psych, was discharged, and went to the detention center on numerous petty offense warrants. All the benefits that was achieved in an inpatient was lost in the detention center, and the person was again very unhealthy. So from that, I went back and was like, we can do better. So that's why whenever we know someone is inpatient and they have charges, we make sure they're represented by the public defender. We will walk them through the system, the criminal justice system, so that they're not going to get lost in the detention center, that they will be out, released to our care, receiving appropriate mental health treatment. Next slide. So intercept 2 and intercept 3, the initial court hearings and jails in the courts. Next slide. So next slide, please. I'm going to start skipping through. So we have trained our entire central booking staff in CIT so that when they recognize someone that is in mental health crisis, so that we can get them treatment as soon as possible. We've actually gone forward to the point that when officers may not have done anything wrong in patrol, they could have followed the law and the letter of the law, the intent of the law. However, it wasn't helpful to a person in mental health crisis that they were arrested. We can actually step in and assist them with that mental health crisis. So with that, we are now getting calls from central booking when someone's in crisis saying, hey, before they go before a court commissioner, can you evaluate to see if maybe they should go to the hospital first? Part of that is putting mental health on parity with traditional health. If someone is arrested and they're having a heart attack, they're not going to be held at the detention center to receive their treatment for their heart attack. They're going to be going to the hospital. We need to do the same for mental health treatment, and I'm proud to say that we are doing that now. Next slide. So Jane's story, and this is one in which the officers didn't necessarily do anything wrong, but they didn't do anything right. So they responded to a well-being check. The person calling in said his daughter has a bipolar diagnosis, was having an episode. Due to the behavior with the officer, she was arrested and transported to central booking. Her behavior that was documented in the report, which was criminal, according to the law, was actually a great, really detailed information of her mental health crisis. So with that, she was released from the commissioner. However, the staff at the detention center recognized that she was in crisis and needed help. So they actually called us. Clinician went out, and we were able to take her on an emergency petition, bed to bed, from the detention center right to the hospital, where she received appropriate inpatient mental health treatment. And how important is that, where she was safe? Next slide, please. So same with bail reviews. We are able to take people when they were at bail review. We'll get calls from the bench, from the judiciary, where they'll call us and say, hey, Steve, can you send a team over? We believe this person's in crisis and needs help. And we're able to take them from the detention center right to the hospital, bed to bed, for appropriate treatment. Next slide, please. So Maria's journey. Maria was arrested for rogue and vagabond when she was in an obvious mental health crisis. Some other things had happened, and she walked away from a hospital emergency room where there was not enough. She wasn't really even seen at the emergency room. It was waiting to be seen. So she was found seated in a car. She was arrested and taken to central booking and remained in a state of psychosis. We were able to, at bail review, advocate for her release. I used to say our custody, but it's not our custody. It's actually our care. So we actually were able to tell the judge and then take her bed to bed from the detention center directly to a hospital for appropriate inpatient treatment, where she's doing really well now. But again, it's everyone working together. And you're going to hear later about that CIT is a community program. It's the public defender's office, the state's attorney's office, the judiciary, and our community mental health resources, where all of us are together working as one to keep the person safe. We're keeping the community safe, but the person with that mental health challenge is a member of the community, and we're obligated to help them in a positive way, not a negative way. Next, please. So post-arrest diversion, referrals from the bench. And that's when we'll receive calls from the judiciary, from our public defenders, from our state's attorneys saying, hey, Steve, can you send a team over? We believe this person is in a mental health crisis, or that's what's leading up to the behavior that got them in trouble. So next slide. And it doesn't always work as planned. But again, it's to keep the person safe. So John's journey, the referral where the judge recognized the behavior leading John's arrest was from a mental health challenge. The judge contacted our CIT crisis response, and we came up with a recovery plan for John. He said he was willing to accept support, and then he was released to our care. And we then, as CIT, transported him to a community provider. Now, as part of his pretrial release was that he had to be compliant to mental health treatment. And that was to keep him safe and do the way we were doing it in the least restrictive way through a community resource. And we would take him to his appointments, hearings, whatever he needs. We would be there as that social support, as his family. Next slide. However, with that, and this is one, and I remember it like it was yesterday because I was actually working overtime when he walked away. And I went, it was a Friday night, and I was covering as an officer in my unit, and went out, and for hours I searched for him, but I was not able to find him. We contacted the judge, and that judge put out a warrant, and it wasn't a warrant to be in a negative way. We were worried about his safety. So the judge put out a warrant. We were able, and one of our patrolmen within 24 hours saw him and was actually able to get him in custody where we could take him to the detention center, which isn't the first, our primary alternative or our choice of treatment, but at least we knew he was safe there and not in danger in the community while he was in mental health crisis. Next slide. So intercepts 4 and 5, reentry and community corrections, please. Next slide. So with that is what can we do to work again as a community to help people in their return into the community, not just from incarceration, but incarceration with a mental health challenge. Next slide. And again, it's just more details of intercept 4 and 5. The next slide. So violation of probations, reentry, diversion. Person has a mental illness, substance abuse disorder. They're on parole or probation. And the question is, are they receiving appropriate treatment for their challenge? So we have a program called Safe Stations, and it's something I haven't talked about, but anyone with addiction can go to any police or fire station or call crisis response, and we will respond, develop a safety plan for them, a treatment plan. We eliminate all barriers to treatment, including those from the criminal justice system, using what I'd like to say common sense. We will take people directly to treatment and not arrest them, even if they have open warrants. The goal is for them to be healthy, and then we'll work with the public defender's office, the state's attorney's office, and the judiciary with the warrants after they are healthy. Next slide. So John's journey. Excuse me. John came to a safe station looking for recovery for substance use. The challenge is once John was sober, his mental health diagnosis was discovered, and he was really, really sick. With that, it was taking him from the inpatient substance use, then to inpatient mental health treatment. Once he was healthy, stabilized, then taking him back to complete his inpatient substance use. Then working with parole and probation, the parole commission, and the judiciary to assure he was receiving appropriate community resources. He was not going to get healthy in jail. He was going to deteriorate, decompensate, and we know that. So the goal is to work with him, be that support and encouragement to keep him healthy using community resources. Because again, that is what CIT is. Next slide. So I believe there's some questions that I'll answer after the next segment. But thank you.
Thank you, Lieutenant Thomas. Hi, I'm Madonna Greer. As said earlier, I'm on the board of CIT International, as well as I'm a part of my local NAMI affiliate. For those who aren't familiar with what NAMI is, that stands for the National Alliance on Mental Illness, a grassroots organization that was started just like y'all, a group of families around a kitchen table to see how they could support, educate, and advocate for their loved ones. So that's what NAMI is. NAMI has been a part of CIT from the beginning. So a little bit of history, the NAMI president in Memphis, Tennessee, when the critical incident happened there, she was one of the first people to the table to say, hey, let's get together, let's get around a table and see how we can problem solve together to have better outcomes, how to keep the officer safe, how to keep the person in crisis safe, so safety for all. So that's how CIT and NAMI kind of intersect and how my two roles intersect. Next slide, please. So a lot of what we've already heard from everyone are on my next couple of slides. So I'm not going to be too tight with my slides. I'm going to kind of overview some of the things we've already heard, which of course is the whole goal here is to de-escalate verbally and then work safely to get that individual to the resources and the care they need. Next slide. So let's just take a minute here to talk about the acronym CIT. A lot of people will think that T stands for training, but it doesn't. It stands for teams. So crisis intervention teams. And we've heard this before, community. The team is the community. It's all the partnerships that come to the table to create a great CIT program. So if your community doesn't have a CIT program, know that you can be a catalyst for bringing CIT to your community and to your local law enforcement. If your local law enforcement agency has one and it's already in place, know that you belong at the leadership table, that CIT is all of us, right? It's the families, it's the people with lived experience that bring that very crucial lens to a CIT program. So be empowered to be a part of CIT, either to start one or if you already have one. As a reference on the CIT International website is a tab that says guide, and that will take you to the CIT International best practice guide. That's like the 101 on how to have a CIT program. You can click on the link there, read it for free, share it with others if you're just starting up a program. So know that the information you need is on the CIT International website to help you get involved. Let's go with the next slide. So CIT actually has two components. Again, most people think it's the training. That's really a very linear, tangible thing, right? You hold a 40-hour training curriculum for X number of officers, and they learn about signs of mental illness. They learn about local resources. They hear from people with lived experience. So at the end of that 40-hour training, those officers leave with a very comprehensive understanding of how to verbally de-escalate someone and how to get them connected to resources in the community in which they live. But really, the intangible but most dynamic part is our other block, that community partnerships, that CIT steering committee, that CIT planning committee that throws the training. That table should have all of the different community members at it. And during those meetings, sometimes is where the smallest little things get worked out that no one knows is becoming a barrier to someone getting the care they need. So at this types of meeting, policies and procedures can be changed. Information sharing, realizing that one person is the steps they're taking might be making something longer than it needs to be. So it's really those conversations that happen when we get around the table and work as partners to problem solve. So I really like people to know that CIT has two components. And if we stop with just the training, what happens is we get really well-trained officers that are trying to divert to a mental health system that isn't working well. And that just creates frustrated officers. So we need that SIMS mapping that you heard about, where you map out your justice partners and your mental health partners, and you see how well you're working together. And if there's gaps, then after that mapping, you can figure out where the gaps are and get funding and be able to fill in some of those spots. So know that CIT has two components. Next slide. And again, we've already talked about some of these, that it's an effective forum for problem solving, community-based programs that bring together law enforcement, mental health, and mental health stakeholders. And that would be all the family members, the people with lived experience coming to the table and being able to express how the system is working and how it's not. We have to remember that those who aren't using the system quite often don't know what's working and not. And so it's really our role to step in and say what we need. And then we also saw from Miriam, when things go really well, we want to make sure we take the time to thank those who've done a really nice job. Like I said a minute ago, just training officers and not improving your crisis system will only create frustrated officers. So we have to really work as community members to improve the infrastructure of the crisis system so that when people are diverted, they have somewhere to get the services they need. Strengthening partnerships across your community. Again, that is just the heart of CIT. One of the things I learned when I first entered into the CIT world was that our first responders have hearts of helpers. So thank you to all our first responders who go in and take care of folks and be there for folks with their hearts of helper. Thank you to you family members and people with lived experience by continuing to work together and partner in the system so that we can create those improvements. Next slide. And so just remember, CIT is more than training. It's a community program. The T stands for teams. So please join the team. If you need any more information, my contact information is available on the CIT International website. Dana, are you taking it from here?
I am. Thank you, Madonna. Thank you so much, Madonna, Lieutenant Thomas, and Muriel for those phenomenal presentations. Bailey, you can take the slides down for now. And we'll jump into our Q&A. We've gotten some great questions in the chat, and you can continue to put those in the chat. I'm going to start with hopefully a simple one for you, Madonna. Do all states have CIT programs? You're on mute.
Yes, at this time, we do have some varying degree of programs in all 50 states, and CIT says CIT International. So we also are working with Canada, Guam, Spain, Europe. Many areas across the world are actually implementing CIT programs.
Oh, that's so wonderful, wonderful to hear. So if a community does not currently have a CIT program, where would be a good starting point to bring the program into conversation with community members, hospitals, and authorities?
Go out and make friends. Make friends with your local law enforcement, any of your first responder communities, your hospital system. CIT is not a cookie cutter. You don't have to do it just one way, right? It's just finding a couple champions in your community and you all getting together, again, going and reading that best practice guide. Inside of there are tips about how to bring together champions, how to write letters to get support. So yeah, it's just have friends, go to CIT International website. And again, we offer technical assistance. You can contact CIT International at any point in time, and they would be happy to help you get you started. And you know, we're here to support you. It is tough to get started, but we're here to support you.
That's wonderful. And I just put that CIT International website in the chat. And Pastor Deb also said National Night Out is a great place to start. Lieutenant Thomas, what has been helpful for your police department in terms of spreading the word about CIT as well to educate the community of its existence and how the community can get involved in CIT?
Absolutely. I think it's success breeds success. And it's our success stories that families spreading. I see one of the participants here is a family that we've helped, and just sharing those stories. Another that no one's hit on is sometimes people question police buy-in. Mm-hmm. And the part where we've had the biggest buy-in is ourselves, mm-hmm. recognizing that we are members of the community. And all of us have our own mental health challenges, and our families and friends have challenges. And a lot of our success has come from the fact that we're helping our officers, civilian employees, and their families as they navigate through the challenges that they have. And that's helped us more than anything. We have an officer now that wants to share his story that he's been recently diagnosed with bipolar, and sharing that now that he's getting appropriate treatment, how much better of a police officer he is and how much better of a family member he is. So with that, it's sharing the stories like we're doing here today that shows the success and how treatment, and it's not cookie cutter. And again, like Madonna said, you have to make it work for you in your community, mm-hmm. and really based on your community resources. And it's more, people get caught up in the training. It's not the training. It's finding those people with the passion to help. Every police office, every police department has them. It's just finding them and then nurturing that to get them. And it becomes contagious.
Yeah. And connecting with people like me and Stephen is great, because a lot of times when you are trying to work with law enforcement, there's an old saying, take a cop to talk to a cop. Mm-hmm. So it is reach into the CIT community. Let us help you find a champion from the law enforcement lens to connect with a law enforcement person if you're having difficulty in that area.
Absolutely. That's a great piece of advice.
Yeah, if I can add to that, and I don't want to dominate this, but we had someone we were helping with substance use mental health challenges had warrants in another state. Mm. So we actually took them to that other state, and officers, and so he had a warrant, and the sheriffs in that jurisdiction were like, is he in custody? And it's like, well, depends how you define custody. So, but he went in and our officer advocated for him. But the point I wanted to get to, that jurisdiction, some of those officers were questioning what he was doing, what our officer was doing. He's like, let me tell you how successful this is. We cut crime in half with our Safe Stations program. We're helping people. Recidivism is only like 8% in our programs. And then that's where they get it, because they start hearing that success of, hey, this is smart policing.
Yeah, absolutely. And thank you for sharing that, Lieutenant Thomas, because this webinar, we focused on what is CIT and how is it done and how does it help families, but it also helps communities because it makes them safer and lowers the crime rate. So thank you so much. Muriel, you mentioned that when you first contacted the police in New Jersey, you requested CIT-trained officers to respond to your son. How did you hear about CIT? How did you know of this program's existence?
When I found out about CIT when it was established in 2007, I was always one of those that was curious and doing a lot of research, asking questions. And then the other thing I must share, I also worked for the state of New Jersey Superior Court. So I that was in criminal, family, and in civil court. So a lot of information was coming through, and especially when you have individuals going through the court system, you kind of hear things. And then I picked up on it, did a little research, and again, NAMI was very much involved in it as well in New Jersey. So it was very easy. I'm just nosy. I'm just like that.
And for families who don't happen to be as well connected and deeply involved in the systems as you, who have loved ones with mental health or substance use crises, how can we educate them about the existence of CIT?
The best way is to engage through, if hopefully, a family run support organization, and just getting them to engage with that family run support organization, because now they're around their peers and they will buy into it more, especially if you have experience going through it. It's a non-clinical approach. It is just basically peer to peer and talking about it. I will tell you this. Now I'm in Florida, but the church I belong to is in New Jersey, and they have a robust mental health ministry. Amazing. They have peer to peer support groups. So now, this time, 2025, I think families can find it through their churches, the places of faith, wherever they go, or a family run family support organization. It's out there, and people are taking mental health seriously because it's affected everyone. Everyone has been affected.
Absolutely. Yeah, we like to say at NFF that we've been making people aware of mental health for more than 2 decades. People are aware. It is time for everyone to accept that mental health is here, and we must adapt and adopt our environments so that we can best support people with behavioral health challenges. So I'm going to ask Stephen a couple of nitty-gritty questions. We got a lot of responses in the chat of people who were not aware of CIT, but were really encouraged and excited about this practice. But they had some questions like, what if an individual is not willing to accept support, but is in crisis and a danger to themselves and others? How does a CIT officer respond in that position?
So that is the most frustrating for all of us. I know families, I can't pronounce it, but anaxnosia, where the person doesn't have the insight into I sort of, in my layman's terms, they're too sick to know they're sick. It can be extremely frustrating. When they are a danger to themselves, that's easy, because then we can take them to the hospital on the emergency petition. And it's sort of, they can be held as long as they are a danger. The more challenging is when they're not a danger to themselves. So they have behavior, their potential for who they are as a person is not allowed to thrive because of their illness. And it's very, very frustrating. Excuse me. So what we need to do is just be thorough, be tenacious, letting the person know that we're there to help them, listening to them, try to, and then going back to that Safer R model, talk to them about positive coping strategies and be there and let them know that we're there to be supportive. But again, it's very, very frustrating. I know for all family members, when you have a person that's refusing to admit or refusing, I guess a better word is to acknowledge that crisis, that their mental health, behavioral health crisis, and they refuse help. And it's just being, again, tenacious, letting them know that we're there to support them. We're there to help them any way we can by being helpful and not hurtful. And that's where the criminal justice system, we have had success. I hate to say volunteering people, but when you give people an option, do you want to be in jail or would you rather be in treatment? And then once they're healthy, and I understand people have a right to be mentally ill. However, for me, my personal opinion, they should be making that determination when they're healthy, not when they're unhealthy.
Yeah. Kind of related question. Is the emergency petition only filed by the CIT officers or the jail, or is that something an individual can request themselves to?
So they can't request it themselves. However, family can go before the court, and a district court or circuit court judge can order the emergency petition. So the family can go petition the court for it. All police officers in the state of Maryland can do it, as well as doctors, independently licensed therapists, and independently licensed social workers can write emergency petitions.
Yeah, great. Madonna, as in your experience training police officers in CIT, what is the biggest barrier to getting buy-in from officers?
We watch it throughout the week. We have people who come to the course that their superiors have advised them to attend, right? They're kind of voluntold, we say. And they come in and they sit like this on day one, And as the week starts to go by, when they go on site visits, all of a sudden they're like, wow, I didn't know there were these resources. And then the people interact. More than one time, we have taken our officers to visit a recovery center where someone who's there, who's speaking, who's decided to speak to the officers, and they'll look around the room and they'll say, you are the person who interacted with me the last time. You made a difference in my life. This is why I'm in recovery right now. So that's always a huge one that gets by it. And then later in the week, we have the family panel and the lived experience panel. So where people in the community like Miriam come in and tell their real story. People will say it helps them find their humanity. So by the end of the week, between the knowledge they get from mental health professionals, information on de-escalation they get from their law enforcement partners, and then the community, the family, the people with lived experience in there telling their stories, it brings officers back to their hearts of helpers, right? If they've been stressed and maxed out, they also go through officer wellness in there. So it's kind of like by the end of the week, it ties it up with a bow and kind of brings them back to a level set, and they're ready to go out there. They have skills, they have resources, they have understanding. And it just really, I love to see the heart of CIT be the last day of training.
Yeah, so perhaps like some preconceived notions about what this is and having to overcome those, right?
Right.
And can I add one thing that we do? One of our clinicians at Crisis has lived experience, and she is a social worker. So she teaches co-occurring our first day, and it's the next to last class. The last class, she then switches hats and teaches and talks about her lived experience and shares her story. So they have her there as the professional, and then it's talking about where she was and telling that story and how powerful it is. And then I apologize, everyone. I feel like I didn't do justice because I skimmed so fast at 100,000 feet up. But Melissa Owens sharing her story as a public school teacher she actually shares a video she took of herself in active psychosis. And it is so powerful for her story of where she was and then where she is now and where she could have been. Again, and I know Madonna said this is really similar thing, but it's just that lived experience of people sharing their stories and family.
And I did forget to mention role plays. The officers do spend about 8 hours of the training doing role plays where they have opportunity to practice these new skills and everything. So that's another important component as they get to do live role plays and interact with people.
Wonderful. Muriel, I know you have been a strong advocate for getting to know your local police department, as you spoke about. When you have tried to support families in doing that, what kind of barriers to buy in from the families have you encountered?
I would say with some of the families that actually have the barrier, it's because of what's going on in the news and things of that nature that makes them say, no, I don't want to call 911. I don't want the police in my house. And I just, again, try to explain that it's all about building those relationships and that trust, just like anything or any type. You can have one nice person over here, then you have a mean person over there. I mean, that's just the way of the world. But I also say that and encourage them if they need that type of guidance, if they need that type of support to connect with someone that can walk that very, like I said, stepping outside of your comfort zone, making you feel uncomfortable.
Mhm.
Sometimes you have to do it. And then you also, and I keep reminding what's in the best interest of your loved one. That's the bottom line. And look, as a parent, and we make sacrifices, whether the child has special needs or not. We all make sacrifices for our children, and even more so when they have a mental health disorder. So I kind of leave it there with them. Well, what's in the best interest of your loved one, of your son or your child or whatever? Wouldn't it be better if they have a trust or a relationship, or at least you have that support to have someone help de-escalate a situation?
Absolutely. That's so
Yeah,
interesting because it's really about the preconceived notions on both sides that
right.
law enforcement officers have these ideas of what criminality versus mental health, behavioral health challenges are, and the families have these preconceived notions about what law enforcement response is. And so it's
Exactly.
building that trust, building that bridge, and having a
Hmm.
community program of CIT to break down those barriers. That's so wonderful.
You know what's really interesting, and which I left out my presentation as well. The trust that my son has with law enforcement now is so interesting. Prior to him moving into another placement, he would actually call 911 before the group home
Oh.
to say, I need help. I need you guys here to help me. And so, and he would tell me, he said, oh, I called, and or the group home would say, he's calling them. I'm like, well, you're not moving fast enough. He's about to have a crisis and he knows it. And so I think that's a good thing, though. That's a good thing. And they've, like I said, they've come to know him and sort of, know what they're walking into.
Absolutely.
Yeah.
We have maybe about 6 more minutes left for questions. We've gotten so many great questions, and so I'm going to try to ask some ones that can have a quick response. So we have Meg, who is in Cincinnati, and she said part of her CIT team is a mobile crisis and licensed clinician to go out with the officer. How common of a practice is that?
It's a growing
We,
field. Stephen, would you?
we yeah, I'm sorry, and I was going to say, and that's part of part of our program is doing that as well. It is really, again, make it work for you and your community. Make it work with your resources.
Mhm.
And
Yeah, great. Then we had someone who was wondering if CIT training is offered to everyone in the department, or is it certain officers? How does that work?
Again, that's where it's not cookie cutter. Each department can make their own personal decisions. First you want to train up those who have a natural heart for that and want to do that, and you might be using them on a team within the department. I think I saw somebody in the comments talking about a small department with 4 to 5 people. You need to train everybody, right? You only have 4 to 5 people to send out. Again, that's individualized. Lieutenant Thomas, did you have something different than that? But that's kind of the way I see most people across the country. Again, it's not cookie cutter.
in a perfect world, you'd want every officer voluntarily want the training. So the goal IACP, the International Association of Chiefs of Police, has what's called a One Mind Pledge, where everyone in the department receives the 8-hour mental health first aid training. And then the goal should be 20% of the department voluntarily getting the training. It's those officers that want it. Like, not everyone can be a homicide detective. So you're not necessarily, or a SWAT. You don't want to train everyone in SWAT because it is a set skill set of people. So you want those people that have that passion to help. They get those tools and skills and understand their community resources. And if I can just say one thing, and I train for CIT International as well as Madonna does. Sam Cochran's 4 plays of de-escalation is so brilliant because it's so simple to do and so easy. And there's so many times I wish I could share body cam. Or you see people's relief. And that's, if you get nothing out of CIT training than that, it's a win. It is so powerful.
Thank you so much. I think we have time for maybe 2 more questions. Is there a database in the police department to know when someone has a behavioral health challenges so that police officers understand how to approach?
So we in Anne Arundel County, I know some other counties, we can actually flag addresses. People can voluntarily sign a release, disclosing whatever information they want to disclose. It could be diagnosis, it could be things that will escalate them and de-escalate them. It could be their information on their social supports, but it's completely up to them. But that's really a county by county, or I should say a jurisdiction by jurisdiction, of what they have available.
Great. And then I'm going to answer this question. We had someone ask how departments can go about finding those trainings. Go to that CIT International that I put in there, or contact Madonna and she'll get you. And then we'll do one last question. Can CIT officers be implemented as an in-house support to incarcerated individuals when they have an episode of psychosis?
Here in North Carolina, we do train the jail staff. So it just depends again on the area, who all you consider to be on your team and who all you want to train in the program. So again, it's not cookie cutter, and we let each community decide what's best for them. But yeah, definitely jail staff can be trained.
Okay. Well, thank you all so much. I think you did a great job of explaining the importance of having CIT, the importance of educating families and those who support families about the existence of CIT, and inspiring everybody on the webinar here to make sure that if their community doesn't have CIT, they get that in the community. And if they do, that they make it not just the training, but that community partnership, building those bridges. And I'd love to close by reading one comment from one of our attendees that really mirrors a lot of the other comments that were left in the chat. Lieutenant Thomas, we need more officers like you. You have helped change my perspective on law enforcement. I've had several bad experiences with police, but I have also had a few good ones as well. And now I know that all officers are not against me. You help prove that. Thank you so much. Thank you all for being here, and thank you so much, SAMHSA, for sponsoring this webinar and the other webinars in this series. And we hope to see you again next year when we're back with a new series. Thank you so much.
Thank you so much to everyone who joined today. This does conclude today's session. You may now disconnect.